My name is John Attia, and I've been asked to do a small session on palliative care for people with dementia. Palliative care is the prevention and relief of suffering in people with life-threatening illness, focusing on suffering in the physical, psychosocial, and spiritual dimensions. Palliative care started out looking mainly at people with cancer, but studies indicate that the burden of suffering in dementia is as great as it is in cancer, but that it's often prolonged. The average lifespan from diagnosis of dementia to death is between 3 to 6 years. So the end-of-life care and the suffering can continue much longer for dementia than it can for cancer. What I'd like to do is use this definition of palliative care as the prevention and relief of suffering, and looking at the physical, psychosocial, and spiritual dimensions as a framework for approaching how palliative care in people with dementia is different than palliative care for people with other life-threatening conditions. So here you'll see across the top the physical, the psychosocial, and the spiritual dimensions, and down the side the prevention and the relief of suffering that were in the definition. And what I'd like to do is speak to each of these 6 boxes in turn, and hopefully that will give you some overall overview of how palliative care for people with dementia differs than those without. So as you see here, in the prevention side for physical symptoms, the main thing here is the Advanced Care Directive. Now, the Advanced Care Directive is a document which puts down on paper the wishes of the person involved with regard to what kind of medical care they want. So it looks at things like if they have a life-threatening infection, do they want to be treated with antibiotics, for example? If they need intubation and they can't breathe on their own, or they need CPR because their heart has stopped, and there's a reversible condition that potentially could be treated. What are the person's own wishes for what they would like doctors to do during that time? And obviously, in people with dementia, the key thing here is to discuss the Advanced Care Directive early, obviously before their cognition or their insight is too affected. And often what I see in practice is that these kinds of discussions happen when people are going to be placed in a nursing home. And by that time, often it's too late with dementia to have meaningful conversations. And really, this is an important area because being transferred back and forth to hospital during those 3 to 6 years that we said is the average time between diagnosis and death can become very problematic for somebody with dementia. Often they do better just staying in their usual place of care. Now we get to the psychosocial aspects of prevention. And this is where, again, having discussions early about who will be the surrogate decision maker is very important. And what I see clinically is that families often have difficulty making decisions on behalf of their loved one because they feel conflicted. And often there is this drive to increase length of time and to do every treatment possible when really the focus needs to be on quality of life. And often prolonging life runs counter to preserving quality of life. So talking about the wishes of the person involved and getting not only that in writing, but doing that with the surrogate decision maker is important. Actually, talking about funeral arrangements can often be awkward, but from my own practice, I find that it's often the kind of opening that people are wishing for, and that often begins an opening for a discussion about what was important in their life, meaning, purpose, and those sorts of discussions. And one big thing is also to look at the will and legal affairs. So it's important to know that now there is a split in the legal division. The power of attorney, or POA, is for financial matters. The medical guardian or the enduring guardian is for medical matters. And often it's important to have the person involved appoint their power of attorney and their enduring guardian before the dementia sets in too far and before their cognitive state is impacted. Because once that happens, they will no longer be able to appoint who they want. It will go to the public guardian or the public trustee. And often that makes things more cumbersome in the long run. Then we move to the spiritual aspect of preventive care, and really this is to think about who is in the best position to discuss and provide help on the spiritual side for the person involved. As I said, those discussions about meaning and purpose, whether there are things that they want to address, unfinished business with family members, with relatives, are there letters that they want to write or conversations they want to have with people before the dementia becomes too advanced? And really, that kind of opening is often a relief that they can have those kinds of discussions before they lose too much of their ability to think and understand. And then we get to the next aspect, which is the relief of symptoms. In the physical sphere, there's a number of symptoms that can happen. Pain is obviously a big one. And once a dementia sets in, it may be hard to express or assess pain, and it may often present as restlessness or agitation. And so it's important to address pain as a potential trigger for agitation. Shortness of breath can often happen, and in that case, morphine is often the best medication we have, not only to take away pain, but also to relieve shortness of breath. And for example, using mechanical fans and doing mouth hygiene, which is to keep the mouth hydrated, often relieves symptoms as well. Agitation is often a big thing with dementia because people don't realize where they are or don't recognize what their environment is. And one thing to keep in mind is that often the medications that we use to treat agitation may work paradoxically in people with dementia. That means that those medications may actually make them more agitated rather than less agitated. So it's usually better to start with non-medication methods to handle agitation. And that's things like getting familiar people around them, keeping them in a familiar environment, having a clock to tell them the time, being able to see outside, and frequently reminding them where they are. Another symptom may be reduced intake. So as people with dementia progress, they will often start to eat less and less. And I want to emphasize that there's a very limited role for a PEG tube here. A PEG tube is a tube that goes directly through the skin into the stomach, through which people can be fed. And often people think that not putting in the PEG tube is the equivalent of starving the person. But in fact, this is a natural decline in appetite, and it's the body's way of kind of shutting down. And particularly in the setting of dementia, it has been found that PEG tubes have a very limited role. And in fact, with the agitation that happens, people can pull them out, they become infected, and they often end up prolonging the suffering rather than reducing the suffering. And this is particularly an issue as the dementia sets in and progresses. People can have difficulty swallowing, and the risk of aspiration and pneumonia can be high because the food goes down the wrong way into the lungs rather than into the stomach. But again, the clinical experience is that putting in a PEG tube in these settings doesn't actually contribute to a prolonged time of life, and in fact makes the quality of life worse. And constipation is also a big thing, and just to be watchful and mindful of using laxatives when needed. The next box is the psychosocial aspects, and this is providing relief in that dimension for the person involved. So often it's about finding the right support, who's the best person who can still have that connection to the person with dementia, But then obviously for the family, there's a burden in caring for people with dementia. It's a big time imposition, and it's quite demanding sometimes to look after people with dementia. So the important thing here is to find people who can help. There may be a community palliative care team in your area that can do visits and can help. And there may be extra services available through government packages that may help with house cleaning, with bathing, with showering, with care for the person. And the thing to keep in mind here is that there is often early and prolonged grief. In many ways with dementia, you lose the person that you knew long before they actually physically die. They're no longer the person that you knew. They're not able to relate in the same way. And so it's important to keep in mind that the grief may happen earlier than when the person dies. And so to be mindful of that and to reach out for support, whether it's from a social worker, a counselor, a psychologist, a psychiatrist, a minister or a pastor, find the help that you need to deal with those feelings. And in the end, when the person does die, obviously spiritual needs, whether it's a chaplain, a minister, a pastor, that you need to reach out to. But also before that happens, the person with the dementia may get some spiritual relief from memories of significance, objects or music, things that had meaning to them, so that even if you can't connect with them using words and they don't have that kind of cognitive ability anymore, sometimes just objects, blankets, pictures, music will often make that connection for you. So what I've tried to do in this table is to kind of go through those three dimensions: physical, psychosocial, and spiritual, and go through the role of palliative care in both prevention and relief, and highlight how these things can differ in somebody with dementia compared to somebody without. And if you keep this little table with these 6 boxes in mind, hopefully that gives you an overview and an introduction into palliative care for people with dementia. Thank you very much for your time, and I hope you found that helpful.